Hi, my name is Annie. As well as being an RN for many decades, I'm pretty sure I have Ehlers-Danlos, and my daughter has a pronounced number of issues and has actually started intake process with the Good Hope Clinic. But I think it's on both sides of the family. And when you were talking about difficulties with labor, with birth and pregnancy and menstruation, my head was like, oh my goodness. So that makes all these other things relevant too, perhaps, because I did a family chart of all the family members and listed symptoms and of who might have what. It's not definitive, but it's a point. But I still get so much feedback from family, some family members going like, oh my God, Annie, would you shut up about Ehlers-Danlos? What difference does it going to make? If my doctor doesn't know about it, how come you think it's such a big deal? And what difference is it going to make? How will knowing make anything change? You can't cure it. So I would like to know if you have a few brilliant words I can use in response to this as I now even expand my search for more details about people's pregnancies and deliveries and PCOS and stuff.
So
thank you.
I think you make a really good point there. And when we look at healthcare from a physician's perspective, or from a lot of lay people that maybe aren't suffering, haven't been through a medical diagnosis that's life altering, a lot of times we draw things as very binary, right? And if there's no cure, why do it? If there's if I'm not going to die from it, why address it? But I think to look at Ehlers-Danlos, I think looking at it at a cellular level, right? So there's intrinsically a difference between people that have it and don't on a cellular level, and how we are as human beings fully formed, right? So when I look at somebody that says, let's say I have Ehlers-Danlos, let's say they come to the clinic and they want to get pregnant, right? And I say, okay, you're in this journey to get pregnant and it's been a long time and you haven't been able to, but maybe you're a little bit apprehensive about using any medication, right? So I would say, or I can look at this data and say, well, listen, if we look at it on a cellular level, we know that it's going to be a slower time, or it looks like there's going to be a slower time. And I think that's really, I don't want to say reassuring, but it helps people maybe cope with having to have more medical intervention, especially when they feel like the major root cause of it isn't being addressed. Another thing is on obstetrics floor, I think everyone knows about, let's say, vascular Ehlers-Danlos, or most people know about vascular Ehlers-Danlos. And why? It's because of that binary thing, right? Where we say, if it's vascular, they have a chance of, rupturing one of their major vessels. So I really need to know about it. But when you look at the things that we found to be higher, particularly the thing about more tears, right? We're in a place now where, thankfully so, we don't do these episiotomies, let's say, for everybody, right? And a lot of times, because we don't do them for everyone, we don't really think about them. We only use it as a last ditch effort, which it should be. But when you look at this data, when somebody's just about to deliver and they have Ehlers-Danlos, you really need to have way more of a understanding of what can happen. I would argue that having a 4th degree tear, right, is for in terms of quality of life is detrimental, right? People do heal from them, and if they're repaired, well, they do heal from them. But you're going to bond less with the baby. You're going to have issues going to the bathroom. It could be lifelong. So I think if you try to take them out of that mentality of this binary where it has to be worst case scenario being helped or not, then it really makes more sense. It's affecting everything in their life, right? And I think people are going to be more likely, and even providers can be more likely to take things seriously and help people with the knock-on effects of Ehlers-Danlos if they take it seriously, right? Sure, we can't cure the overarching theme, right? But I think if we're aware of the things that can happen, it leaves a little bit more understanding. I know people, if they have children that are going through, let's say, puberty, and they know that these things can happen, it leaves you better prepared. Me as a physician, sure, I can treat these things, but if you're, let's say, a family member of someone, you have no medical background, being aware of these things, I think, helps a lot. So you can be in tune, you can help support your child, your family member, your friend, even yourself, right?
Thank you, Dr. Hasan. Just a few questions from the chat, and then we have a few more live questions. This one's from Carrie. Will we get a link to the published research study when it's completed?
So good question. Next week, I'm going to be presenting my poster presentation for the research. Now, this only has a part of it, right? There's so much information there, and obviously the manuscript is much longer. We're going to do a poster presentation on May 5th at the University of Toronto's Research Day. Obviously from there, we're going to get some feedback. The advantage of putting it on a scale like that in front of all the colleagues is that, there's different ideas about how statistical analysis should be done and what should be included and more, and if there's any subset analysis we need to add. After that, we take some time, look at the manuscript, and then we're going to submit it for publishing. So we just, overall the entire study is done, right? And the write-up is also done. But before I want to go and publish it onto a journal where it's going to be essentially critiqued. So I want people to be able to look at it from our department to see what can be improved a little bit.
That's great. So we have Leila and Alana. First, Leila from the participants.
Hi, Dr. Hasan. Thank you for your wonderful presentation. I learned a lot. So I have a couple of different questions. Maybe I missed this at the beginning, but do you happen to have a relationship with the Good Hope Clinic by any chance? Because I've heard from other people that have it, that when they've gone, they've left feeling hopeless, like not really getting a diagnosis.
So I think I touched on a little bit, not specifically with the Good Hope Clinic, but the problem with how healthcare is set up is, there's I don't want to say a territorialness, but there's a bit of a disconnect between, different services. If you're in the same hospital, then you're more likely to work with people and you kind of know who to refer to. I think the advantage of maybe these larger teaching hospitals that we're part of as residents is that we feel like all the resources are all around us, right? So we're not really aware of when you go out, maybe just like 50 kilometers out, it's like a completely different thing, completely, right? And as far as I know, me being an obs-and-gynae resident, 4 years in, the biggest high-risk obstetric center in the country here at Mount Sinai, I don't know who to refer to if somebody has Ehlers-Danlos. I would refer them to a high-risk obstetrician, but is there someone specifically? For example, if somebody has, let's say, a form of hemolytic anemia or a genetic form of anemia, right? In my mind, I already have a person that I know looks after these patients. I know, right? If somebody has an issue with cancer diagnosis in pregnancy, I know who. If somebody has really bad endometriosis, I know who. But when it comes down to Ehlers-Danlos, I don't. I truly don't, right? So I think the problem is finding somebody who is, number one, knowledgeable on it and is a bridge between those two things, right? If you notice with most chronic diseases, the clinics that are providing care for them, they're really multidisciplinary, right? They cover all different services and they have a person in mind. Whereas I feel like in obstetric gynecology, at least to my knowledge, I don't know anyone that does.
Okay, because I'm just thinking, because I heard it's a 2 to 3 year waiting list. I don't live in Toronto, so to wait 2 to 3 years, then get down there and to be kind of shied away, it's like, what's the point really? And because I thought they were the experts at the end of the day.
Yeah, and what I will say as a point of getting a diagnosis, right? If we look at Ehlers-Danlos as, let's say, this is a connective tissue disorder, right? And it's either that you have it or you don't, right? I feel like, and this is just a personal opinion, right? I feel like if people are having symptoms that are very related to it, but we're not able to diagnose a specific subset objectively with like a test itself to tell you, then really there should be research for people that have the symptoms as well. If you came and you said, I have lower back pain, right? Mm-hmm. And I say, okay, these are the causes of lower back pain, and these are people that treat them. If you came in and you didn't have any of these causes, I would still be treating you, right? Whereas it doesn't really work for Ehlers-Danlos. And I think it's because of a poor knowledge overall from the healthcare system of Ehlers-Danlos, right? I'm sure that the experts on Ehlers-Danlos from, let's say, internal medicine, they know more about the ins and outs of it, right? And during the research work, like I said, when I was going through TikTok and things, I saw a lot of people that said, well, I went to one clinic and they said, I was essentially shied away from them. And then another clinic that did way more extensive testing actually diagnosed me with it, right? And it's hard to say how to fill that gap, right? I think the only way it can be done is for us to advocate moving forward. And the problem is these 3-year wait times, I think, reflect something really important here. The 3-year wait times reflect that there is not enough expertise. If there was a lot, all the people that are waiting on the wait list would be funneled to many different people. But here you're looking at, one place trying to see everyone. And when you're in that situation, you're looking at more patients. It's harder to take your time with one person to really explore everything about it, right? So, that could be contributing. As for what I think will improve it, someone has to take an interest, right? More people have to take an interest. I think the more it becomes, and this is the unfortunate reality, the more things become in the mainstream and the news and people are talking about it, the more interesting it becomes for physicians even to go into those fields and address them. But I think that's what's going to take, right?
Okay, if I could ask, I don't know how much time we have, but if I could ask just a couple more questions.
I'm okay with that.
Okay, so the presenter before you, Dr. Zagani, I think her name was, or Fagani, she had an image of the prolapse types. I know you didn't really speak on this topic, but do you know how can you get a proper diagnosis of what kind of prolapse you have?
That's an easy thing. So as part of the questionnaire that was done, essentially a quarter of the data that was there was done by one of my colleagues, Dr. Olkchuk, right? And she published her paper on the outcomes with pelvic organ prolapse. And here it says Dr. Cody McDermott. So Dr. McDermott, who's in this study, has another paper on pelvic organ prolapse. But any gynecologist should be able to tell you what degree of prolapse you have, right? So there's a few different forms, a few different degrees. But if you want somebody who's ultra specialized in prolapse, then it'll be something called the urogynecologist. So URO, and then gynecologist. And there's, the good thing about that is there's a lot of them. Obviously, they also do have wait times, but any gynecologist should be able to tell you if you at least have prolapse, right?
And they did, but I didn't know there's like all those 6 different kinds, or they just said, oh, prolapse, and then they were shocked because I've never had a child. Right? So, like, they were baffled by it. So it just explains a lot. And then a geneticist, I know you spoke about this topic a bit in your presentation. I was turned away. They won't take people that don't have cancer, in their history. And so EDS wasn't a good enough reason for them to take me. So do you know how to advocate for myself where I can potentially meet with a geneticist, or does the Good Hope Clinic do that, to your knowledge?
I'm not sure if the Good Hope Clinic does that. The thing is about genetics, and just facing a little bit about the reality of it, right, is, these rules and rules on who gets tested and who doesn't get tested is, based on statistics and cost benefit. And that's the truth, right? And getting into those clinics to be able to be tested, usually they want an objective end result for why you're being tested, right? Let's say I have a really strong family history of, let's say, breast cancer, and they say, okay, I'll look at the genetics of it and I'll be able to tell if you need to or not. I can't tell you if there's anyone who does it outside of that realm. I know it's frustrating, but I don't really have too good of answers for that.
Okay. All right. Okay. Thank you so much.
Thanks.
Thank you, Leila. We have time for one more question, and then everyone else in the chat will definitely send your questions to Dr. Hasan, and hopefully he could help you with that. So, Ilana.
Hi, can you hear me? Sorry. Actually, I was a preemie. I had 3 preemies, which is interesting. So I had 32, 35, 36 weeks. My blood pressure went way up and my water broke on its own. I was a patient, Dr. Summers he was at TGH, now he's at Mount Sinai. But I have more of a general question. I've known for a while that I had looser joints, and I was always told when you're pregnant towards the end, there's a hormone that is released called relaxin. And the people that have hypermobile joints, that hormone can cause a lot of problems later on in pregnancy, like dislocating your pelvis, your hips. So what precautions do you tell women that have this propensity to have this hormone that's released that relaxes your muscles when they don't need to be, ligaments when they don't need to be relaxed?
I think that's a good question. Now, even in the study, what I didn't publish there is the rates of dislocations that we had during pregnancy. The problem is giving advice on that is we couldn't stratify them by basis of if these happened during the pregnancy overall, or if these happened during just the delivery process, right? I think if we're talking about the delivery process itself, then you know how they use this, how they use the stirrups and during delivery. I think there's ways you can mitigate it when you're talking about just delivery itself, right? And the ways you're going to mitigate it is just the angle the pelvis is at, as well as the angles the knees are going to be at. There's a tendency that providers do where they kind of push onto the legs and they apply this traction to be able to just curl the body a little bit and allow that, that nice curve for delivery to become easier. But I think if somebody has Ehlers-Danlos, then you shouldn't really do that. Give it more time, right? Give it more time, be wary of how it happens, and just let it happen, right? Instead of trying to be a little bit more forceful. Now, can we do anything during the pregnancy process? That's a little bit harder, right? Because there isn't anything that I can say has, absolute proof that it will decrease it. Probably taking it a little bit easier, but I think that's just general advice, right?
Like a physio, a chiropractor, an osteopath, and then another person that really needs to be involved is the anesthesiologist, because we have so many problems with drugs and not freezing and hypermetabolic drugs. That's a whole other can of worms to open up. You need a whole team. You don't need just the obstetrician. You need a whole team of people.
I think the point about the anesthesiologist is extremely important, right? I want to make a comment on it from the anesthesia side. I actually emailed one of my colleagues, one of the residents about it, but they haven't gone back to me, so I can't really give you an answer. But I would tend to agree with that, because I think with the way you look at it is, they have vascular EDS, you need to be really careful. But then again, there's so many other factors.
It's all EDS. It's not just vascular. Yeah, it's all types.
Yeah.
The drug interactions and the drug reactions are really important. And that has to be discussed way before labor, because if you have to do a section and the wound doesn't freeze, there's all sorts of things that could become a potential problem if it's not talked about.
What I would like, if I was going to say an ideal world, we have pregnancy clinics, especially at Mount Sinai. There's a pregnancy clinic for almost everything you can think about, right? And it's a great place to be. But I would like, if not an EDS clinic in pregnancy, an EDS and some, right, where people can have it's a one place where you could go see your obstetrician, at the same time speak to anesthesiologist, be followed through the pregnancy as well as need be, and then that way you're going to actually strengthen it, because you have all these residents coming through Mount Sinai. They're going to be exposed to many more patients that have EDS, as well as some other connective tissue diseases. I think that's what needs to happen. It needs to be like a clinic day where all people with EDS or even other connective diseases are seen together, right? I think that's probably the best way moving forward.
Thank you.